I get invited to speak a lot, and just because my fortunate position, just like you guys did in Israel and had the unfortunate happenings in 2006, and it makes you better leaders, it makes you better people, it makes us better researchers, and if there is such a thing as good things that come out of war, what does come out is, we value the research and education and the money that gets poured into preparedness, and it gives us a wake-up call. So I hope I can share a few things that I learned in Iraq and through Afghanistan, and some of the trauma lessons that we learned there. As I travel, we wear uniforms a lot. I give this talk. As you become the rank, as my colleague just alluded to, we were both colonels. When you get to be a colonel, then you get your own driver, which is kind of cool, So I go around to these venues, and my driver one day was kind of mad at me. He goes, "I don't understand. You get invited, and all you do is read the slides, and everybody stands and loves you." I said, "Well, if it's so easy, why don't you do it?" So we switched rank real quick. I pulled up to a venue, last venue, and I let him do the speech, and pretend it was me. And he, of course, just read the slides, and everybody ooh-wooed and loved it. But he forgot one thing. At the very end of the talk, they go, "Do you mind taking some questions?" So, of course, somebody in the audience is like, "Well, how would you logistically supply cash, and, how much equipment would you use, et cetera, et cetera." And for a minute, he just stood there, and then he said, that's one of the stupidest questions I've ever heard in my life. That question is so easy, I'm going to have my driver answer that in the back. So anyway. All right, so we do have a sense of humor in the military. I'm going to mention a few products that we utilize. A lot of these you already know about. So some of you that don't work in trauma care don't realize that you actually are in the cutting edge, and I'm very proud to be affiliated with Rambam. You guys are doing the right thing, healing, teaching, and discovery, or research as we call it. You're right where you need to be. A lot of these things are not going to be eye-opening, but I'm just going to reiterate some of the things that we often forget sometimes, and what we need to endorse, to do better care. So I am kind of a funny guy. My medical center is in San Antonio. If you want to visit, we have the largest military training facility now in the world. We train all the medics. There's 39,000 Army medics, and there's Navy, Corpsmen, and the Air Force. We've now combined down in San Antonio. I don't have to kill you, so you can come actually visit if you want. I can give you a tour. So I'll give you my email at the end. If you're ever in San Antonio, Texas, please visit us. Our basketball team lost last night, though, darn it, so I don't know how we're going to do. But anyway, Spurs. But so I want to apologize about some of the slides. We do have trauma slides, but I hope to limit them to educational purposes, so I'll show you a few things. So here we go. So I'm not the expert, but I do have a T-shirt. What I mean by that is I've been there, and I've done that. And I'm thankful for those that are on the front lines, especially your IDF and your EMS people that do daily dangerous jobs that go out into the environment. So I salute those people. And most of the time, humans live despite what we do to them. I figured out that they're resilient. So despite some of the medicine we do or don't do. So we'll have a little bit of fun along the way. I'll tell a few jokes. But I think the biggest lessons that you guys have learned, along with the Americans, and a lot of our colleagues throughout the world, is utilizing the best practice or the best evidence now that we can, even though evidence is certainly limited in the disaster type of setting. But I think here at Rambam, as you guys are going to cut the ribbon on your new underground facility, which is quite impressive, you know the point of rehearsal and how important it is to rehearse with the equipment. A lot of times we kind of just walk through the areas and kind of do our drills, et cetera, and don't pull out the equipment and stuff. And you guys have realized that, especially in 2006, how important it is to be familiar with the training and equipment of your colleagues and what we're going to utilize. So, and then there are some scope of practice issues I'll talk about. The Israelis don't deal with a lot of the things that we have to deal with the FDA and licensing, et cetera. But we'll mention that because it's kind of important to talk about, scope of care and standard of care. Does it really change during a disaster setting? I'll reiterate this. Our trauma management really strategies depend on current epidemiology and injury and death patterns, and you certainly are aware of that. I think that's what we need to know. So we've had our own problems, as you guys know. Here's your rocket attack in 2006, as you know. And then I think the biggest thing that we've learned is the military can share a lot of things that we've learned, because a lot of times just natural disasters, et cetera, can become a tactical situation, as you know, especially living on your soil here in Israel. All right, so here, hopefully at the end, there'll be a rainbow at the end of the talk here. All right. So here we go. First thing is I mentioned working with real heroes. I really appreciate that. That's one of my first lessons that, these people that go out into the field in the front. But what we really need to know is that, the austere environment can be difficult, and challenging. And you guys remember in your conflict, you had delayed transport times, and you had even people without the ability to transport. So you had to do some sort of point of care or care at the site of injury for a while. So we certainly learned how to do kind of limited care. We know that if we can get the casualties to a level 1 trauma center, or such as the trauma center in Rambam, that you have about a 95% chance of living, which is amazing. But sometimes you can't get them, so they're quick enough. Sometimes you have challenges out in the austere environment. This is an evacuation of a special ops soldier there in Afghanistan. Now, that isn't blood. A lot of people are always worried that that's blood on the side it isn't. It's where you throw the smoke grenade to have the chopper come in. So, but that was one of our casualties. So as you developed your underground facility, you realize that, how do you equip it? We realize that sometimes when a limited resource or limited constraint environment, some of the equipment and issues certainly don't apply in your daily routine trauma care. So the daily trauma patients that come in Rambam are usually easily taken care of because you have an excellent team here, that takes care of them. Often, though, when you have mass casualty situations, things that you don't normally expect can go wrong. So we'll talk about some of those things. Another thing is when we practice medicine in these type of environments, sometimes that can be bad tactics and get people killed. So even though we feel like we're practicing good medicine, sometimes you have to take in the tactical situation into account, and we'll talk about that as we go on. I think you're doing a great job, Gila, and you guys doing the education, standardizing and doing standardized education and training throughout the country, utilizing your IDF and working with them, EMS and IDF together, having the same type of equipment and training is very important. You guys have learned that, and I can't reiterate that enough. I mean, if you don't standardize it, especially the equipment, then a lot of people are unfamiliar when things go wrong. We don't really have the luxury sometimes of over triage, and that means, in a car wreck, we know everybody's going to come to Rambam. It's right here. We can take them there. But if you have 70 or 80 casualties, not everybody can come right to the trauma center immediately. You can't send everybody to the level 1 trauma center sometimes. Expectant category, I know we don't like to talk about that, but one of our challenges ethically is prior to these events is you need to have an ethics committee sit down and kind of decide what you're going to do with people. You can't throw the kitchen sink at everyone, and we realize that in some of these environments. So these are conversations that need to happen prior to these events on what you're going to do with, pain management, blood management. What are you going to do when people have devastating injuries and they probably won't recover? So these are conversations that need to happen now, and you guys are already having them, and you already have boards. Research, you're doing that here. I think it's fairly limited right now on the battlefield, but you guys are starting to work with us. One of my favorite jokes is because of the limited research that we have in some of the trauma centers and disaster centers, people kind of doubt the validity of it because you only have a couple case series or case report. I remember we were talking about, utilizing the tourniquet on the battlefield when we first started developing it with you guys, the Israelis in the early 2000s. People were like, well, you haven't proven that tourniquet works. Well, nobody's really proven parachutes work either. So there was an article in the British Journal as a joke that compared parachutes and no parachutes. So it was kind of a joke. They said, well, nobody's ever proven parachutes work, so now we have to do a randomized trial and randomize people to get a parachute and not get a parachute, see if it works. So I say that tongue-in-cheekly because a lot of things that we do in trauma management aren't validated 100%. We think we try to do some of the research, and then when we look at it, then we try to prove if it works or not. So some of the things can't be proven up front. We know personal protective equipment works. That's a very important thing that you guys have also utilized and learned up front. We also know that the explosive injuries, we used to, remember early in your literature when you had the blast injuries in your discos and your markets, a lot of people were worried about the blast wave, but we really realized that really the mortality and morbidity comes from the secondary injuries and the tertiary injuries. So it's penetrating and blunt trauma. So early on, we probably over-concentrated kind of on the blast wave and blast lung, and really that's overrated when you're in an outside area like the rocket attack you guys experienced. And the quaternary injuries as well, the burns and other things that can happen. We talked about some of the literature. I'm not going to go over all the studies. I have them at my reach. A lot of things I'm going to mention. If you want it back by literature, I can show you. But a couple of the slides I just want to go over is that we really have done a great job, like you guys have, at managing trauma on the battlefield. And we realize that most people die in the pre-hospital setting, so that's where we can really make the most impact, as you guys have learned, the trauma and emergency medicine EMS systems out there. Most people die from hemorrhage, as we know, so that's kind of what we concentrated on, and other things, airway issues and breathing issues. We've concentrated on training and educating. I mentioned that. This is something that we are working with your IDF. We now are training our flight guys to be paramedic level EMS providers, so we want them to be more critically care advanced. We are losing a lot of people en route, especially just like you guys, we had long, prolonged evacuation time. So in your Lebanon war, you had some issues with, evacuation and people needing critical care, and it's, you're going to have to train the way you fight and train these people up to a higher level or a standard level that they normally wouldn't in a regular situation. These are kind of the other areas, and we'll go over just a few of them before I finish, but these are kind of the things that I can show you some literature that we were really concentrating on besides hemorrhage control and airway, and a lot of these things that you guys are already utilizing in your trauma center on a daily basis. We're looking at maybe a way to add sensors. You guys have some advanced monitoring here as well, especially when you open up your center down there. You're going to have very nice monitors, the ability to kind of have some sort of dashboard. We really want to be able to put these on soldiers somehow and be able to monitor them remotely using kind of some advanced vital signs. This is a lot of the data that we were looking at, some of the advanced exciting things. We now have the ability to do a non-invasive hemoglobin monitoring, which is very exciting. So we don't have an iStat obviously on a chopper. So we're probably one step away from being able to look at the lethal triad, which I'll mention in a second. Lactate and acidosis, et cetera. Maybe do that through a monitor one day. So that we're probably not that far from that. You guys have been very instrumental in tourniquet use and hemostatic agents. I remember when the Army first went in, we had these little green cravats we used to use, and they go, well, you just put a cloth around somebody and take a stick and tie it, and it'll use as a tourniquet. But then we realized, if you ever tried to find a stick in Iraq, it's a little difficult. So we learned how to have a windlass tourniquet there at the bottom, and we use a lot of different agents now. It says only the dog knows for sure. Sorry, it's not my kit. I stole it from the internet. But there are a lot of nice new powders and things that you guys have developed. The Israeli uses Celox and Woundstat, and we have combat gauze. So a lot of these things you already have you guys are already using some of this in your EDs, right? I don't know if your ambulance have a lot of these, but the soldiers carry these advanced hemostatic agents now on the battlefield to prevent external bleeding. Our next goal is to look at internal bleeding. There's a couple companies now that are looking at squirting stuff in people, either foam or some type of gel to stop hemostasis, so internally, which is exciting. And I can provide you some literature of that. And then we know about damage control resuscitation, especially my trauma colleagues. There's a lot of different great literature out there and really about fluid management, blood management, keeping casualties warm. This was a big lesson we didn't really talk about applying on the battlefield, because people forget that when you get shocky, that you get cold, and the colder you are, you get coagulopathic. And it's just something we didn't really realize. I mean, when you have 30 casualties laying out there and you get this lethal triad, we were losing people. One of the major vital signs, temperature, is something you don't usually take, on these mass casualty situations. And they came in cold. We used to try to heat fluids and casualties up any way we could. That's an MRE. I don't know if you guys know what MREs are, meals rejected by Ethiopians. They're like these little meals ready to eat that the military uses, but they have little heaters in them, and so we were actually using them to warm fluids. But you guys have the fluid warmers and the bear huggers, but you don't have 30 bear huggers. So we developed some different ways to use warming blankets, et cetera. And then I'm not going to go into all this literature, but I think some of the newer things about using kind of a more component therapy and a walking donor. Israelis, you guys are certainly not ignorant to the blood supply, and you do have a very robust way to get blood fast. In the military, it sometimes can be very difficult. In fact, some of your local corporations are trying to develop freeze-dried blood now. So we want to have the ability to pull your blood out, freeze it, and then you can carry it on yourself, and then reconstitute it and give it back to yourself. So I think that's very exciting. A couple of your companies are very close to getting an FDA approval to do that. So I think that's exciting. Pain control, something else we learned that we weren't doing a very good job. And it's, this does never let a firefighter babysit your kids. But so we developed some fentanyl lollipops and some ketamine. And what we really realized was, morphine's a great drug and narcotics are great. But if you use a multimodal approach, then you can decrease PTSD. I don't know if you remember the Colonel slide, but did you guys see how many people just sought treatment in 2006 for stress and stress-related thing? We learned that in the military. Injuries, can be psychological as well. So we need to really keep pain control on the forefront, which is something that we didn't do a good job at early in Iraq and the war. And in-route care I mentioned. So this is the big one. How are we going to critically take care of people through education and training? I think that was one of the biggest lessons. So I think the biggest thing is you guys are smart at allocating your resources. You're doing that. There's a new paradigm now. You really have concentrated on what you need to learn from your experience in 2006 and our experience in Iraq. Well, we work with the IDF, and we actually have people come over, as you guys know, and train with you at Sheba and Rambam and other medical facilities, as well as you guys come to the U.S. and train with us. Standard of care is really important, and we talked about maybe even having a prior committee before disasters happen so that you can ethically decide early on so that there isn't any problems. We actually had a physician charged with murder during Katrina because she didn't utilize resources appropriately, and there was really no ethical board, and some of her patients died. And so if you don't talk about this beforehand, you can get in trouble. So I think the final thoughts are where we're going in the future, and I think with closed loop therapy and the use of computers and technology is very exciting, like your use of Atom. I think these are very important concepts. The problem is technology usually doesn't save lives. It usually ends up complicating stuff, but there are some great advances out there that we are looking at. The decision support systems that we're developing with you guys in critical care are quite exciting, where that you're basically hands off the patient. You kind of let a computer deliver the fluid, deliver the glucose, deliver the pain management, deliver ventilations and stuff. So I think the future is very bright in trauma and disaster care due to these wars and technology. So I think the final thoughts are train adequately. When you hear footsteps, think horses, don't think zebras. I mean, common things kill people, the ABCs. Work on your surge principles and capacity. You guys have developed that perfectly with your garage in a way to expand appropriately. I think that's perfect. Always practice using multi-agencies, and you guys do that well, Israelis. And pre-designate your metrics and equipment and your research guidelines before you go into the situation. So I know our jobs can stink sometimes. They're tough decisions, out there, when you're talking about mass casualty and disaster planning. But I think the biggest thing is what you guys have done here very well is be creative. You've been absolutely creative, and it's a joy to kind of see my colleagues, the professors here and the workers here, come together, and to see this center become so robust, it's very exciting. The next 4 or 5 years are going to be very exciting for Rambam and the faculty here. So I want to thank my colleagues and the people that are at war right now who risk their lives. That they're also going through rough times right now. So I want to thank our troops. And if you have any questions, I guess we're doing questions afterward. I appreciate your time. Thank you.